Today we are going to discuss about the metabolic bone diseases, which includes the rickets and osteomalacia. Now, the mainly rickets and osteomalacia are both happens because of the deficiency in the calcium and vitamin D. Now, mainly we have to understand that the difference between the rickets and osteomalacia is the place where it is affecting. Now, the rickets means that there is the inadequate deposition of mineral in the growth plate, whereas osteomalacia is where there is no proper deposition of mineral in the osteoid, which is present in the cortical or trabecular bone. Now, the cortical and trabecular bone are seen both in children as well as in adults, but the growth plate is usually seen only in the children. That's why rickets and osteomalacia both can coexist in childhood, whereas in adults it is only the osteomalacia which will be usually present. Now, vitamin D is taken orally and it is absorbed, and then this will be converted into calcium. So there are three things. One is calciol, calcidiol, and calcitriol. The calciol happens in the skin after the first hydroxylation that happens. Then it goes to the liver where the second hydroxylation happens. And once it goes to the kidney, there will be third hydroxylation happening. And that's when the active calcitriol is formed. Now, as I told, it can be taken in the dietary source, as the natural sources are usually present as calciferol, or we can present as supplement that we give usually present as ergocalciferol. Now this all will be converted into calcitriol, and that's what is the active form. Now this calcitriol is responsible for its action on the bone. This calcitriol acts on the bone and it causes the resorption of the bone, where the calcium is released from the bone. Also, this calcitriol acts on the kidney, and the calcium as well as phosphate is absorbed into the blood. And other than this, it will also affect on the intestine, and it will causes absorption of the calcium and phosphate into the blood. So mainly the vitamin D absorbs the calcium and phosphate from the intestine, from the kidney, and from the bone, thus causing an increase in the level of the calcium as well as phosphate in the blood. Now, what does parathyroid hormone do? Now, the parathyroid hormone is stimulated when there is low calcium level. Now, only function of a parathyroid hormone is to maintain the blood level of calcium. Now, parathyroid hormone doesn't have anything to do with phosphate. So, what does parathyroid hormone do? Now, the parathyroid hormone, first thing it does is it prevents the calcium and phosphate from accumulating in the bone. So, by this, it is keeping the calcium and phosphate in the blood, and it will increase the resorption by the osteoclastic activity. It pulls the calcium and phosphate into the blood. The second place where this acts includes that it acts on the kidney. In the kidney, it acts on two places. One is the proximal convoluted tubule, and the other one is the distal convoluted tubule. Now, this is the proximal convoluted tubule where the phosphate is absorbed, and this is the distal convoluted tubule where the calcium is absorbed. Now, parathyroid hormone goes and inhibits the absorption of phosphate and increases the absorption of the calcium. By this, it will cause increase in the level of the calcium in the blood and decreases the level of the phosphate. The phosphate is excreted in the urine. Now, because of this, the parathyroid hormone causes increased calcium and decreased phosphate, whereas the calcitriol, that is vitamin D, causes increase in the calcium as well as the phosphate level. Now, if you go and see the biochemical analysis of this, there are variable changes that are happening. Now, the first thing is the alkaline phosphatase increase because there is continuous resorption happening from the bone. The calcium level is low because of the low intake of the calcium. The phosphate is also low because of the increase in the parathyroid hormone. Whenever there is nutritional deficiency of the calcium, parathyroid hormone increases, which tries to absorb calcium and excretes phosphate, because of which there is low phosphate, and parathyroid hormone is high because there is low calcium. And vitamin D deficiency itself will cause nutritional leakage, so vitamin D is usually lower in these patients. Now, in the bone, we'll see like this: the porotic bone, that is the bone is not dense because there is no calcium deposition that is happening. Now, if you see a bone, it has an epiphysis, it has a physis, nothing but the growth plate, then it has a metaphysis. Metaphysis is the part which is the first area where the growth plate will start producing the bone, and it will be depositing as a metaphysis. Now, in the physis, there are multiple areas. That is, there is a reserve zone or the resting zone, there is a proliferating zone, there is a hypertrophic zone, calcification zone, and zone of ossification. Total of 5 zones are there. The reserve zone is a place where there is no activity, there is no multiplication of the cell. It is the cells which are reserved themselves for the further mitosis and proliferation and increasing the number of cells. Now, this is the cells which are waiting for proliferation, but there is no activity as of now. There is glycogen stored inside this cells, because of which this is a site where the glycogen storage disease happens, and this glycogen is stored so that during the mitosis it needs to produce a lot of energy, uses this glycogen to produce all the energies. So glycogen storage disease affects this resting zone or the reserve zone. Now the proliferative zone is these cells, once it get them into multiplication or mitosis, this is called as a proliferative zone, where the lengthening of the bone happens, and because it is mitosis is happening, there is metabolic activity seen here, and this is where the dwarfism and gigantism effects at this proliferative zone. Now, next zone is the hypertrophic zone, where all the metabolites for that is required for a mature bone is produced at this level, because there is no multiplication anymore. Multiplication is done. Now these cells will mature themselves and become fatter, fills themselves with all the food items that they are required for forming of a mature bone. So the cell size increases and undergoes maturation. Because of this, the cell size is larger. It is easy for the cells to slip over each other because they are not arranged compact, because they are fatter. Because of this, the physeal trauma affects this area most commonly. The next zone is where the cells undergo apoptosis, and it will undergo calcification of the cells so that it will become stronger and it will give the tensile strength to the bone. So the calcification happens from this level, and this is where the rickets primarily affect, and this is that zone of calcification where the rickets is getting affected. Now once this undergoes calcified, now it gets its blood supply from the metaphyseal vessels. Now once it gets blood supply from the metaphyseal vessels, it is called as ossified. Now this is the proper bone formation. Now, as I told, there is an epiphyseal artery, there is a metaphyseal artery. There are two separate arteries supplying two separate parts of the bone. In between, we have the physis, very important when it comes to the spreading of infection. An infection at this level, metaphysis, will not go to the epiphysis because physis acts as a protective area. So that's one point that based on the blood supply we have to remember. And there is a ligament which connects the epiphysis to metaphysis, called as a ring of Lacroix. Now, how exactly bone is formed? The bone is formed whenever an osteoblast starts depositing, producing type 1 collagen. Now, bone has bone, it has 1 in the name. So the collagen that deposits itself is the type 1 collagen. So bone has type 1 collagen, which is produced by the osteoblast. Now this, once a collagen is deposited, it is called as osteoid. Now once the osteoid is formed, it is unmineralized, it is non-calcified, it has to undergo calcification. Once it's calcified, it's called as osteon. Now the osteon is a calcified osteoid, but this is calcified now, but it has to be continuously undergoing decalcification as well as calcification to maintain its tensile strength. So it will be continuously acted upon by the osteoclastic resorption, and it will be continuously mineralized by the calcium. If this doesn't happen, it will not have its tensile strength. Now because of this, it is acted upon by the osteoclastic cells. Now there are various diseases which act at different levels of this cycle. Now the first thing is the osteogenesis imperfecta, which happens because of COL1A1 gene mutation, so which will cause defective collagen production, so the bone becomes weak and brittle. Now once, if it has passed this step, that is collagen is normal, but if the calcification is defective, then we call it as osteomalacia or rickets. Now, once even the osteoid formation is fine, osteon formation is fine, but the resorption is not happening properly. The bone is not getting resorbed, so the bone becomes thicker and thicker. That is osteopetrosis. But this bone is not strong. As I told, there should be a continuous resorption and new bone formation for a bone to be stronger. Now, exactly opposite to osteopetrosis, there is a disease which causes maximum osteoclastic activity and bone becomes weak that way also. That is osteoporosis. There are two different spectrum of the same step that are happening. Now, there is one more step which affects the osteoblastic activity. It increases the osteoblastic activity as well as it increases the osteoclastic activity, and that is the Paget's disease. So these are the different disease acting at the same cycle at different points. Now, what happens in rickets and osteomalacia is that the osteoblasts which are produced, which produces collagen, normal type 1 collagen is produced, then it forms osteoid, which will get mineralized, which has to get mineralized to form osteon. But what happens in osteomalacia or rickets? This calcification is not happening. So what happens? The osteoid keep on increasing, but there is no osteon formation. Because of that, this, if you do a biochemical analysis or a biopsy and see the level of osteoid to osteon, the ratio of osteoid to osteon ratio increases because of the amount of osteoid which increases. Now, in a bone, there is collagen. Inside this collagen, there should be deposition of calcium. Now, whenever the calcium is the deposition of calcium is reduced, it can be because of increased osteoclastic activity, or because it can be because of decreased deposition. Now, whenever it is because of decreased deposition, we call it as osteomalacia. Whenever it is because of increased osteoclastic activity, we call it osteoporosis. But there is one more difference in these two. Now, in the osteoporosis, there is something called as collagenase which is produced. Now, this collagenase causes breakdown of the collagen. Because of this, in the vertebral bodies, we see vertical and horizontal trabeculae. Now, the horizontal trabeculae are lost in the osteoporosis. Now, in osteomalacia, there is no collagen is not reduced, but disorganized collagen is what is seen. But in case of osteoporosis, the amount of collagen is usually reduced. That's the basic difference between these two diseases, though the mechanism is different, and also some amount of the pathology is also different. Now, we as I told, the absorption of the vitamin D happens from the gut and it goes to the skin. In the skin, it has to be acted upon by the sun to undergo UV light, to undergo first hydroxylation, then it goes to the liver, the second hydroxylation, it goes to the kidney, third hydroxylation. So any diseases of the kidney, there is no third hydroxylation. Any disease of the liver, there is no second hydroxylation. Any non-exposure to sun, the less exposure to sunlight, again there is no first hydroxylation. No absorption itself, then again there is less of vitamin D, and dietary intake is reduced. These all are the causes of rickets and osteomalacia. Now, what exactly happens in the rickets? Now, as I told, the rickets mainly affects at the growth plate. This is how the normally growth plate will look. We have a diaphysis, then we have a metaphysis, we have a physis or the growth plate, then we have a epiphysis. Now, what happens when there is rickets? Now, when there is rickets, as I told, there is no the calcification or mineralization of the osteoid. So there is no osteon formation, there is no calcified bone formation. Instead, there is uncalcified osteoid keep on depositing. So in the physis, the uncalcified osteoid keeps on depositing and it becomes thicker and thicker. And one more thing is the phosphate will usually cause the cell to undergo apoptosis for the calcification to happen. Now, what happens when there is calcium deficiency? There will be parathyroid increasing. What happens when there is parathyroid increase? It will cause reduction in the phosphate. And as I told, there is less phosphate now. But what did I tell? Phosphate is required for the apoptosis to happen, so that the mineralization of the calcium can happen. So there is no apoptosis, there is no cell death. So the cartilage keep on growing. It will not undergo bone formation because there is no phosphate. So the cartilage keep on thickening, the growth plate thickens, so the growth plate, the space becomes widened. So widened growth plate is one of the important feature of the rickets. Now once the growth plate has increased, now we see this one dense line here in the metaphysis called as a zone of calcification, the provisional zone of calcification. Now it is a zone where the calcification happens in the physis, the junction of the growth plate and the metaphysis is where the calcification is supposed to happen. But in rickets, what happens to this growth plate? Now, what happens to this zone of calcification is that there is no calcification happening at this zone because there is no calcium. So because of which there is loss of this zone of calcification, as well as the zone, there is no calcification and there is no pressure. When the pressure falls, it will be not sustained because there is no calcification, there is a soft bone down, so it will push the metaphysis outward. That's why there was this splaying of metaphysis. The metaphysis is splaying outwards. Now once the metaphysis is splaying, now still there is more pressure on this soft bone. What happens to this soft bone? This soft bone will develop irregularity and this fraying happens in the bone. So this is called as the irregularity or the fraying of the bone. So we had splaying of the bone and then the irregularity, the fraying of the bone, and this depression formed here is called as a cupping of the metaphysis. So in the metaphysis, what do we see? Splaying, fraying and cupping is what we see in the metaphysis, and this classical appearance which looks like a paintbrush is called as a paintbrush metaphysis. So these are the changes happens around the growth plate because of the rickets. Now what happens in osteomalacia? In osteomalacia, the first thing that happens is generalized osteopenia, generalized hypodense bone, generalized osteopenic bones. Bones will look more and more blacker because of no calcium deposition. The second most important thing and the most specific for these rickets and osteomalacia, mainly, sorry, not rickets, osteomalacia, because it is affecting the non-growth plate areas. That is, there will be presence of this loser zone. Now, what is loser zone? Loser zone is nothing but unossified or uncalcified osteoid deposition, which looks like a lucent line in the bone, which we may think of fracture. That's why it's called pseudo fracture or the loser zone, because it's discovered by Emil Loser. Now this is nothing but a lucent, radiolucent area which goes perpendicular to the cortex, and it doesn't completely cover the circumference of the femur or any bone, and it will be usually perpendicular to the cortex. Now there is no callus formation because this is not a actual fracture. But other important thing we have to remember here is the most common site of this is in the pubic symphysis, the pubic rami, and the second most common site is the medial aspect of the bilateral femur, and this is usually bilateral symmetric. Now the other areas where it can affect includes the scapula, the bilateral forearm bones. It also can be affected, but these are called as a loser zone. Now what happens in the vertebral body? In the vertebral body, mainly we see generalized osteopenia. That's why it looks more and more blacker or the grayish in appearance, and it can have some biconcave appearance because of the compression, and also there might be some fractures present in the vertebral body. The fractures are common in any of these diseases, metabolic diseases, because of the weakening of the bone, and it is seen in even in the rickets and osteomalacia. So this is the first image which is showing that the metaphysis is widened, and we can see some irregularities in the metaphysis. Again, even in this image we can see some irregularities in the metaphysis. The bone is looking very osteopenic. Epiphysis is not clearly seen. Both the epiphyses are not clearly seen. There is flaying, splaying, fraying, and even cupping of the metaphysis is seen like in this image, what we classically call as a paintbrush metaphysis. In this image, if you trace the anterior ribs, there will be widening of this anterior ribs. Why there is widening of the anterior ribs? See, anterior rib, end of the rib is where there is costochondral junction. There's a cartilage which is attaching to the bone. Now there is a new bone formation at the level of the costochondral junction, and the bone is weak. So first thing happens is the bony part which is attaching to the cartilaginous part, there will be depression of this the bony part, and there will be a cupping of the anterior end of the ribs. And because of the same changes playing, like we see in the metaphysis, we see the similar kind of playing here, which will give the knob-like appearance at the costochondral junction. So if this knob-like appearance along all the anterior end of all the ribs, when we palpate, you feel like a nodules which is fed like a the rosary that we used to pray. Now that's why it is called as the rachitic rosary. In the rickets, whatever the rosary kind of appearance we get is called as rachitic rosary kind of appearance. Now in this is one more image which is showing similar nodular kind of thickening of the anterior end of the rib at the costochondral junction, which is classical of the rickets. Now these are the images which are showing these looser zones. We can see some lucent lines along the long bones. We can see a lucent line along the pubic rami, and here also again we can see a lucent line along the pubic rami. Also, I told osteomalacia will be associated with fractures. We can see how the fracture is irregularly present, which is not horizontal to the cortex. It is oblique, almost at 20 to 30 degree to the cortex. It's not at 90 degree. If you see this the loser zone, it is exactly 90 degree. If you see any loser zone or pseudo fracture, it will be like that. But this subtrochanteric fracture is not at 90 degrees, so it is a fracture, not a pseudo fracture. Now this is one more image which is showing the pseudo fracture. One more thing to remember is the pseudo fracture usually happens in the medial end. If it happens on the lateral end, we think of something like bisphosphonate poisoning, which is seen in older patients in whom there is severe osteoporosis. We give bisphosphonate. The lateral fracture suggests that there is bisphosphonate. Again, multiple loser zones are seen in this image. We can see the lucent area within the bone, the blackening of the bone because of the lack of the calcification in the osteoid. Now this is one more image which is showing the scapula, which is showing bilaterally symmetrical loser zones. Also it is showing the forearm bones that are the radius and ulna, again showing the loser zone in this image, bilaterally symmetrical. The other thing that can happen is because of the softening of the bones, there will be bowing of the bones. When the weight is borne on the limbs, there will be bowing of the limbs, is one more feature of the rickets. Other thing that can happen is in the suture line, the two suture won't be fused because again it is soft bone, not calcified. Uncalcified osteoid will be present there also, so it is no, the fusion doesn't happen in the skull bones. The other thing that happen in the children when the bone is very soft, in any case of rickets or osteomalacia, the osteomalacia name itself means malacia means the softening of osteo means bone is softened. So in rickets and osteomalacia there is bone softening. So when the child is lying down in supine position, usually the age group is affected includes the 6 to 12 years of age. The most of the time the child will be in the lying down position. So the skull is most dependent, and it will be the normal curvature is the convex curvature because of the dependent pressure on the occipital area. It will be appearing flat. So flat occiput, square shaped the skull are all the features of rickets. Again, I didn't find an image, that's why I just put this image. Now when we start giving treatment in a patient of the rickets, again see, if you see this metaphysis, a patient with treated rickets, it is having little bit of cupping, but we cannot see that clear cut flaying, and fraying is not clearly seen. Mild splaying we can say it is there, but what is classical is this reappearance of this sclerotic line, or the provisional zone of calcification will be reappearing in this patient, and that is the most sensitive finding in the x-ray that will tell us the healing has started. And the earliest finding in the healing rickets is the reappearance of the zone of provisional calcification. Now the symptoms of the rickets includes in a 6 to 12 months of age a patient we usually present with irritability, tetany, because calcium is will usually block the sodium channel. So sodium is not going inside the cell. If the sodium goes inside the cell, it will undergo the activation of the cell and it will undergo muscle contraction. So sodium channels are not protected by the calcium now, so undergoes tetany, and because of the continuous muscle action there will be weakness, delayed maturity, and deformity, and all the changes will be seen here. And as I told, the metaphysis is involved, the zone of calcification, the provisional zone of calcification is lost. It's the first to reappear in the healing. Cartilage cells in the physis are affected. So They fail to calcify and degenerate, because of which all the changes that I told, widening of the growth plate, paintbrush metaphysis, loss of zone of calcification. Epiphysis can also be frayed, like how the metaphysis was taking all the pressure. Even the epiphysis is weak because there is no calcification, even that can undergo a little bit of fraying. And bowing deformity, the fractures, the decreased bony length, scoliosis, pseudo fractures, the loser zone, and the rachitic rosary. In case of osteomalacia, the muscle weakness and bone pain and deformities will be the symptoms. And as I told, there will be elevated parathormone, alkaline phosphatase, because bone is getting demineralized. Hydroxyapatite will be hydroxyproline also will be elevated in this patient, and normal or decreased calcium and phosphate based on how much of parathyroid hormone is acting and all that. Now, imaging wise, there will be generalized decrease in the density. Coarse trabecular pattern will be present. As I told, osteomalacia, the arrangement of the collagen is abnormal, but there is no reduction in the number of collagen, and loss of cortical definition because of thinning of the cortical bone, no calcification happening there, and there will be loser zone. Loser zone is very specific to osteomalacia, and along with that, there can be deformities as well. So in general, in rickets, these are the overall pattern that we have to remember. That in the extremity, widening of the growth plate, irregularity, paintbrush metaphysis we have to remember, and in the chest, rachitic rosary. Also there will be bell-shaped thorax, but bell-shaped thorax can also be seen in some dysplasias as well. In the skull, the flat occiput, the square, the widened suture, the squaring appearance of the skull, and basilar invagination is the other finding. The basilar invagination is nothing but the odontoid process of the C2 vertebral body will be present along with the anterior arch of the C1 vertebral body, held by a transverse ligament. Because all the bones have become softened, now it will not stay in its position, it will be protruding inside the foramen magnum. That itself, the protrusion of the odontoid process inside the foramen magnum, leaving the C1 vertebral body behind, it's called as a basilar invagination. Of the healing rickets, the most important thing to know is the cupping might persist, widening of the growth plate might persist, but the reappearance of the zone of calcification is the first sign to be seen. So this is how we do imaging of rickets and osteomalacia.